Home of Medicine podcast with me, Dr. a.Burbridge. I'm a consultant in acute and general internal medicine in the UK.
Hi, Ben Lovell here. I'm also a consultant in acute and general medicine in the UK, but we're not in the UK today.
We are not in the UK. So Ben, where are we?
We are doing an extra special episode of the podcast in Florence, in Italy, in Firenze. That's my Italian accent.
Excellent.
So I say buongiorno a tutti. We've never done a live podcast before. We normally record these in the safety of our own kitchens and our own homes, but we've been invited very kindly to come out by the European Federation of Internal Medicine, and we are here speaking at the European Congress of Internal Medicine in Florence with a lovely audience of people who are passionate about internal medicine from across Europe and maybe beyond.
Yes.
So it's going to be a very different type of podcast today, where I'll be asking you what you think, but I'll also be turning to an invisible audience, which people listening at home can't see, but I promise you they're there, and asking what they think as well. So it's going to be slightly different today, but we're very excited.
Excellent. So I know nothing about the case that Ben's going to tell me about. So as I often do in clinical medicine, I may do things that people disagree with or may not be wrong, because in clinical practice, we aren't right all of the time. So over to you, Ben. You've got a case for me.
I just want to check. You can't see my notes before we get
I
good.
Can't.
We're not cheating. So this is a case I met recently on the wards. It was an acute admission to the acute medicine unit, and it was an 83-year-old man with pain in his leg. Okay? Pain in the left hip going down the left thigh. The pain came on suddenly 1 day ago. A sharp stabbing pain from the hip going down the anterior thigh. And it was so bad he couldn't walk. Usually he can walk, but he's been so much pain, he can't even weight bear on that leg, according to his family. And there was no trauma. He didn't fall, he didn't twist, he didn't do anything traumatic to the leg. It just suddenly started hurting, the hip going down the thigh. And he didn't really have any back pain that went with it either. I asked a bit of history. This has never happened before. He does not have a formal diagnosis of a rheumatological condition. He's 83, so maybe he has osteoarthritis, but this is a sudden onset change. And the pain, as I say, hip going down the anterior thigh and a little bit around the left sacroiliac joint as well. And that's the initial presentation. What are your initial thoughts?
Okay, an 83-year-old male with leg pain, left hip pain, thigh pain, 1 day history down the anterior leg, and he can't weight bear.
Yep.
So this is really feeding into my neurophobia, because I really get scared of neurology cases. May not necessarily be neurological, it could be musculoskeletal.
But that's weird, because you love MSK cases. You love rheumatology, but you don't like neuro. But you've decided this is a neuro. Okay, this is a neuro case.
Okay, could be neurological, could be musculoskeletal. I'm worried about his hip. Even though he hasn't had any trauma, he could still have fractured his hip. There could be a pathological fracture there. He could have an underlying malignancy that we don't know anything about. He could be very hypercalcemic. There could be underlying prostatic cancers with lesions, osteoclastic lesions and osteolytic lesions, maybe from multiple myeloma within the bone that has caused a pathological fracture. So that's something that's going on in my head. Other things I'd be thinking of, radiculopathies, potentially. So is there some nerve damage somewhere along the line? Any bowel or bladder problems?
No, neither.
No. Any pins and needles?
Well, he says no, but I'll get to the examination in a bit. There was some altered sensation, but at that point of presentation, he denied numbness, tingling, any paresthetic symptoms along the leg.
Okay. And when you say he was unable to weight bear, was he unable to weight bear on both legs or just one side?
On that left leg, and he was screaming in pain. He was given IV morphine in A&E because the pain was so severe.
Okay. Shall we open it up to the audience and see if they've got any questions that they want to ask? Okay. Any thoughts? I'm stuck.
Is he on any medication? Is he on any medication? He is on some tablets. He's on Ramipril. He's on aspirin. He's on alendronic acid. He's on calcium, and he's on benzofumethiazide.
Why is he on calcium?
A lot of people are on chalk tablets.
They are, that's true.
Now, when I was training, I was told that you have to give a bisphosphonate so they can suck up all the calcium, but you've then got to give them calcium so they can suck it up into the bone, which I now understand is nonsense. Am I right?
Yeah.
I'm speaking to the rheumatologist.
You are.
Yeah.
So bisphosphonates work. I always imagine they coat the bone with hydroxyapatite crystals, and they take, one of the roles is take calcium from the serum into the bone to strengthen them, as well as affecting osteoblastic activity.
Have you seen the size of a calci-chew tablet, by the way?
They're huge.
I once published a case report, and you could find it, of an older gentleman who was on calci-chew tablets, and he didn't understand you were to chew them. So he was trying to swallow it whole. And there's a beautiful X-ray where it was an X-ray of his chest, and right in the middle was this big, bright, white, shining medallion, which was his calci-chew tablet stuck right in the middle of his esophagus. And ever since then, I ditched the chalk tablets.
Yeah, I'm not a big fan,
Yeah.
I have to say. Particularly after a certain age, they're really difficult to take. They don't taste very nice.
Do they taste of chalk?
They're really chalky.
Yeah.
Yeah. Okay, so we've had past medical history. We've had medication. So actually, have you had past medical history?
No.
Okay.
So the past medical history is that he has high blood pressure. And this is the most important thing for me when I was considering this case, was he had atrial fibrillation and he had previous DVTs. And for both of those things, he was taking another tablet, which I didn't mention before, which was rivaroxaban.
Okay.
Why are you nodding wisely, if I may ask? Member of the audience.
It's an important addition for the differential diagnosis of
Yeah.
his left hip pain.
How is it an important differential diagnosis?
Because even though he already had DVTs in the past and is on anticoagulation medication, there could still be a problem.
Are you wondering whether he's got a new DVT? Okay. So a big proximal DVT, maybe something sitting in the iliac vein that would cause severe pain in the thigh and swelling as well. We haven't examined him yet, but yeah, okay, that's a good thought. He says he was completely compliant with his rivaroxaban, but we can see.
I would think about more like a bleeding complication.
Bleeding, yeah.
Muscle, suddenly, spontaneously in older patients with anticoagulation.
So just for the mic, you're worrying about whether there was some kind of spontaneous hemorrhage in the context of a DOAC, of a oral anticoagulant. Where about would the bleeding be, do you think, to cause that presentation?
Psoas muscle. We always forget about the psoas muscle, don't we? That's a really good point, actually.
She didn't forget.
I forgot. No. Sorry. I always forget about the psoas muscle because it's a bit higher up, isn't it? So, but actually, when you think about it, yeah, it could be a psoas muscle hemorrhage, definitely.
Okay.
Okay.
Any other thoughts before I progress?
Still on the statin.
He's not on a statin.
Good question.
What are you wondering about with the statin?
Pretty awful. Or statin-induced myalgia.
Statin-induced myalgia.
Yeah.
It was a sudden onset pain, to be unusual. And I'd also expect a statin-induced myopathy to be more bilateral rather than, it was very clear it was excruciating left-sided pain. Yeah. I read a review article a very long time ago that's saying that it's so rare it almost doesn't exist, statin-induced myopathy.
Yeah.
Is that true? I keep asking you vaguely rheumatological questions.
Yeah, absolutely. And I think there's a lot of concern over statins inducing myopathy, but actually in clinical practice, I don't think I've ever seen it. You see a very mildly elevated CK, 200, 250, but would that cause
that should be
huge,
asymptomatic?
Exactly, yeah. Quite.
I'm sure I read a review which said that more people in the placebo group developed muscular pain following initiation of treatment than actually in the statin group. And because it reached sort of public consciousness in the media a few years ago.
Yeah.
And I wonder if that had something to do with it. Anyway, interesting side note.
So at the moment then, we've got an 83-year-old gentleman
Yes.
with leg pain, hip pain, thigh pain, unable to weight bear with no trauma. He's hypertensive. He's got AF. He's had a previous DVT and he's on a DOAC. And so far we've thought about, could this be a further blood clot? Could it be a DVT? Could it be a psoas muscle hemorrhage? We've talked about, could it be a myopathy, radiculopathy? Could this be a nerve abnormality? Okay, so did he complain of heat?
Where?
Like in his leg? Was it hot? Was it hot to touch? Was it tender?
It was very tender.
Okay.
But he did not mention heat, no. I mean, shall I tell you the examination
Yes, please.
findings? So I examined him and to the naked eye, both legs looked normal. One was not bigger than the other. There was no redness, no bruising to indicate he'd had a trauma that he maybe didn't remember. There was no skin changes like a cellulitic changes or any rashes. He was in so much pain, I could barely touch the left leg. He couldn't tolerate active nor passive elevation of the leg, even 1 degree, without screaming. And this was with 5 milligrams of intravenous morphine on board. And he did have impaired sensation over the L2 and L3 dermatomes. So the anterior thigh. Now, he didn't notice that until I got my needle out and started pricking him with it. But there was impaired sensation in that area. But I really couldn't examine the hip, and I couldn't even examine the knee or the ankle because he couldn't tolerate those vibrations of movement moving up into the hip joint because the pain was so severe. I had to leave that leg alone.
Now, something's just come into my mind, and this could be completely bonkers: compartment syndrome.
What compartment?
I'm just thinking pain, exquisitely tender to touch. I've seen that before, and it's been compartment syndrome.
We've done an episode on
We
that.
have,
Yeah.
but it's normally been preceded by exercise or a fracture or something like that. So it's not going to be that. But I think when we are thinking of diagnoses in clinical practice, it's important to say out loud that, oh, is this compartment syndrome? No, it isn't. And it isn't compartment syndrome because there's been no injury. It's in an odd position to have that, and it doesn't fit the clinical picture. But it's really important that we vocalize those conditions so as we can then rule them out.
Do you mean the thigh, like of the thigh muscles?
Yeah.
Yeah. You'd expect there to be a swelling though, right?
Yeah.
You expect the thigh to be thick. It's interesting because I actually did go down a similar sort of thought process to you, and we did request a CK. But that was normal. It was about 400, so vaguely raised, but very non-specific in the context of how he presented.
Okay.
Okay.
Mm-hmm.
So that's my examination. He had good pulses in that leg. The leg was warm and well perfused, and his reflexes were fine. But boy, he did not like me checking his reflexes on that left leg. He was in a lot of pain.
What about his observations? If you just go back to basics, blood pressure, heart rate, temperature.
Yep. Heart rate was elevated at 122 in atrial fibrillation, known AF. Okay. His blood pressure was slightly elevated, 140/90, in the context of screaming pain.
Okay.
Right. His respiratory rate was normal. His oxygen saturations were normal. He was afebrile, so his temperature was normal.
Okay. Chest.
Chest was clear.
Heart sounds.
Normal.
Abdomen.
Fine.
Okay. So everything was completely normal apart from this unilateral leg pain.
Yes.
Okay.
What am I going to do now?
What we're going to do now?
Was there any hernia, any inguinal hernia? No. I've got to say, as a medic, I'm useless at examining for hernias. So unless it's poking me in the eye, I don't know if I'd miss them all. But I think I'd see a strangulated one, but I didn't see one.
Okay. Why did you ask whether there was a hernia or not? What's your thought process?
Referred pain.
Okay. Yeah.
So we're thinking about referred pain from an umbilical hernia. Okay. I really struggled to roll him over to assess. I think there was pain that from the left hip was going round to the sacroiliac area. I don't think there was any spinal tenderness that I could get my hands on, but I was really rummaging underneath his whole weight. So in the pelvic area. He was uncomfortable in the lumbar area. He was, but I've got to say, I know I keep saying it, my examination was really limited by pain. I always want to do a really good examination like I did in my membership exams, a really perfect examination. When a patient's screaming and begging you to stop, it's quite hard sometimes to tune that out. I've seen different approaches to that, actually. And I think I take different approaches, maybe depending on how I'm feeling on the day.
Yeah.
But sometimes when someone screams stop, I sort of do stop because I do worry about consent and people saying, don't touch me there, and I touch them. Sometimes if I really am trying to rule out a very serious diagnosis, I would not say rough, but I'm a bit more insistent. Like, I'm really sorry, I've got to have a look at this. It'll be over soon. Let me have a look. There we go. All done. And I'm trying not to scream. I sometimes wonder how midwives and obstetricians manage to think clearly in the heat of the delivery room when the woman in labor is screaming, and they're making very calm, informed decisions about safe directions of travel for them and their baby. But it's something that I do sometimes have to actively tune out when a patient's in great distress, and also have I given them enough painkillers?
Exactly. Yeah. You were going to say
So roughly isometric is an argument to
yes. That's what,
Yes, so we were titrating morphine in. I know there's no upper limit to morphine, but when you get to 20 milligrams of IV morphine on someone who's still in a lot of pain, that's when I start to get it myself. That's just my own personal, like a twitchy area where I start to think something's gone awry here, especially if they're opioid naive, like this gentleman was, because I'm sort of getting into general anesthetic territory. Where he might drop his respiratory rate to 3. Where's he going to be where we'll notice if he suddenly has a respiratory arrest? The honest answer, in a corridor in A&E, with someone walking past every sort of half an hour or so. So I do get a little bit nervous with the morphine. I know the A&E, the emergency department people are much more gung-ho. Even as recently as a year or so ago, a consultant, said to an A&E consultant, I've given this woman 20 milligrams of morphine and she's still screaming. What do you think I should do? He went, give us some more. Like, what a stupid question. And I was like, I guess so. But I do get it. That's sort of my grey area for morphine, because I'm unused to that level of pain in my patients.
I also think that we often go straight for morphine, which is obviously patients in huge amounts of pain, but often we can also utilize other pain medications at the same time because they can work synergistically together.
Like what?
So intravenous paracetamol.
Do you like that?
It can work in some cases. So that's a possibility. Was it muscular spasm? Would diazepam have helped potentially? Because sometimes if a patient's in huge amounts of pain or discomfort or tension, diazepam can help. So last year I was personally really unwell and I had severe pain and I refused morphine. Because I was scared of having a respiratory rate of 3.
Gosh.
And I refused it and refused it and refused it until I could no longer refuse it. And they gave me 10 milligrams of morphine and I was opiate naive and the pain didn't go. And they gave me another 5 milligrams and another 5 milligrams and eventually the pain settled. So when you are in that amount of pain, it didn't have any adverse effects on me, but the pain went. And as soon as that pain went, I could literally feel my body go, oh. I mean, it was literally overwhelming, the relief. And I think because I was in so much pain, because I was getting more anxious, the pain felt worse almost. Because I was incredibly anxious and my heart rate was up, my blood pressure was up. So I think we probably can be a little bit more generous with morphine. It's difficult though.
It's for me, it's the monitoring. It's the monitoring issue that makes me a bit nervous. I would hate to give a big dose of morphine and walk away.
Yeah.
And then you come back later and the patient's blue. But that's my fear. It's probably unfounded. Where's that fear come from, Ben? I don't know. But if someone is screaming in pain, we cannot leave them like that. I don't know if I'm convinced with IV morphine. I've got a feeling it's a very expensive way of giving morphine when an oral route would do just as well.
Well, I did have Oromorph before the IV morphine.
Oh, is it useless?
And the Oromorph didn't touch the pain.
Yes.
So I think it depends on where the pain is, the severity of the pain, and also we're all different. So the way that you respond to pain and I respond to pain is very different. And I sometimes don't think that we take that into account with medications. Just because it may work for somebody, might not work for somebody else.
Oh, yeah, I've been there myself. I had to have surgery a few years ago and I came round in the recovery room in a great state of distress with pain. And they must have been bolusing me with something, with morphine, and I couldn't see in my cannula. And I said, I'm still in agony. And he said to me, you can't be, because you've had 35 milligrams of morphine over the last hour. And I didn't know how to respond to that. I was like, I can't be in pain. I don't know what to say.
Yeah.
I'm almost crying. And it was weird because I'd never thought of it that way before. Your pain can't be that bad because this amount of painkiller works. And it leaves you a bit nowhere because you've got to say, well, it didn't work for me, sunshine. I don't know what to say. I'm in agony over here.
And I had tridoxycodone as well. We literally sound like we're some sort of
We
drug
sound very,
users.
very ill people.
And it didn't work for me at all. So again, it is very different, I think, isn't it? We're all genetically different as well, aren't we? So moving on from that, absolutely, palpate the lumbar spine. Has there been any fractures potentially? Or is this discitis?
Okay.
Sudden onset of pain, no fever. It doesn't really fit that
It was
picture.
sudden.
Yeah.
No, as you say, I'll get to his blood test in a minute. Discitis, I have seen, it does cause excruciating levels of pain and they cannot mobilize their spine. It was just not, it wasn't quite in the right, I was fixated on the hip.
Yeah.
I was worried about an occult fracture,
Yeah.
like you were at the beginning.
Yeah.
A pathological fracture.
Okay.
Um,
But the calcium was okay in the alk phos?
yes. So blood tests wise,
Yeah.
the hemoglobin was 99, which is 9.9 in old money.
Yeah.
Platelets were 130.
So a little bit low.
White cells were 8.
Yeah.
Neutrophils were 6.1.
So white cells and neutrophils are normal.
Normal.
Platelets are a little bit low. Hemoglobin's low.
Yeah.
Okay.
Sodium, normal, 138. Potassium, normal, 4.1. Creatinine, normal, 76. CRP, 8. Low.
Okay. So those blood tests then, I guess, with a normal white cell count, neutrophil count, normal CRP, rule out potent infection. So discitis doesn't seem very likely.
It goes against
It goes against
Yeah.
it, exactly. It's still not impossible. The low platelet count, we talked about bleeding. So the platelets are low, they're on a DOAC. There's 2 reasons, therefore, that this patient could be bleeding. So that goes up in my list of possibilities. I'm still not sure whether there's a fracture or not until I've actually imaged the joint itself.
Yeah.
This still could be a radiculopathy. Until I've got any imaging, I'm not really sure what's going on there. Hemoglobin of 99. So MCV, mean corpuscular volume.
Was normal.
So this could be an anemia of chronic disease.
It's funny that's leapt out to you because, yeah, it is low, you're right. I don't know if I notice hemoglobins in older people so much, unless it's dramatically off. I remember once being on a post-take ward round at 7 a.m. after doing a night shift, and I had you know how different consultants have different areas of interest. We might
Yeah.
say whims.
Yeah.
And this consultant's whim was hemoglobins, and every patient he was saying, so why do you think the hemoglobin's 108? And I was sort of sleep deprived, and like they've come in with rip-roaring sepsis and pneumonia. I didn't look at the hemoglobin. I didn't find that very interesting. But so I don't know if I noticed the hemoglobin 99 in this patient, to be honest.
That would raise alarm bells in me. With a normal MCV, slightly low HB, could this be due to a chronic inflammatory process that's going on, potentially, such as a malignancy, possibly? Is this, again, I'm going to go a bit left field here, with the thigh pain, it's not that. I'm just sort of thinking an autoimmune condition.
Sudden onset, though.
Yeah, I know it's not. But you don't know it's sudden onset because often when you go back and take a history, the history might change. And when you ask specific questions, they say, actually, I have had bilateral thigh pain and I am having difficulty raising my arms. And sometimes you have to ask specific questions to tease out diagnoses such as polymyalgia rheumatica. I'm not saying that it's that, but it's that sort of thing that
I know exactly what you mean. I'm going to be devil's advocate for 1 second. I think with a lot of persistence, you can get patients to admit to anything you want them to. If you've got a diagnosis in your head and you're trying to make it fit.
So you're framing
I get this a lot,
the story.
I get this a lot with thunderclap headache. No one can see my air quotes. Thunderclap headaches.
Yeah.
And they get referred to me, sudden onset headache, you must rule out a subarachnoid hemorrhage. And I don't want to do a lumbar puncture. So I myself and other people, we go to the patient and say, are you sure it was sudden onset? And they go, yeah. And you go, what exactly were you doing? I was watching TV. Well, that's quite a long-term activity. That it could have been how many hours are you watching TV? And you wheedle and eventually the patients give up and say, you're right, it came on over a long period of time.
I've had it for 7
And I go,
months.
there you go, no lumbar puncture needed. And I think with enough tenacity, you can get patients, if you've got a diagnosis in your brain that you really want to make, you can sometimes sort of push so one has to watch it, I think.
Yeah,
You have
absolutely.
to have an open mind whilst going through a Rolodex of potential diagnoses in your head at the same time and working out what fits.
But that's also being aware of our own cognitive biases. So, for example, I know when I take a history, because of my rheumatology background, I will tend to focus on rheumatological conditions. So, polymyalgia popped up then because I spent years training in rheumatology. So I think I'm aware of that and I keep that in check, but I absolutely know what you mean. You have to be. Okay, so we've got some investigations. We've got a normal CK, you said, mildly elevated.
Yeah.
Full blood count using his liver function.
Was normal.
Okay, normal liver function tests. Bone profile.
Normal.
Vitamin D levels.
Didn't do them.
Okay.
Sorry.
I guess not really relevant.
It's not
in the
part of
acute
my
setting.
sort of front door screen. I can add them on later, but I didn't have them at this point.
Did you do a D-dimer?
No.
Okay.
Should I have done?
No, I never do them. But the reason I'm asking is because we mentioned a DVT.
Yeah.
It's not a a blood test that I'm particularly fond of because of its, if it's positive, then it leads you into a whole realm of investigations when actually sometimes a good history and examination would help, but I just thought I'd check that. Okay. Platelets are a little bit low.
What are you going to do? Apart from get his pain under control.
Getting that pain under control is really, really important. And maybe it's more morphine, but maybe it's about adding in some paracetamol or some diazepam or something else that may also help with that. We really need some imaging.
What imaging would you like?
I'd want to look at the hip.
Yeah.
I want to x-ray the hip.
Plain x-ray.
If you can tolerate that, where in the hospital that I work, it's very difficult to get any more in-depth imaging unless you've done the basics first. So the first thing they'd say is, well, let's do a plain x-ray of the hip because they'd want to see if there's any fracture. If he was still in pain, the x-ray was normal, then they would do a CT hip if necessary.
Okay.
So that's something we'd think about. I want to look at the spine. I want to see if there's any nerve compression. So I could do an MRI. Could there be an infarct in one of the arteries within the spine? Again, I'm thinking weirdly.
So a spinal stroke, sudden onset spinal. I mean, you can.
Doesn't really cause pain, I guess.
Yeah, you get like Brown-Séquard syndrome.
Yeah.
You'd expect a motor. To be fair, I could not do a motor examination of that leg, so I couldn't tell you what his power was.
Okay.
So I'll tell you, we got an X-ray, plain X-ray. Simple question: is there a fracture? Simple answer came back no.
No. Okay. Anybody else? What else? Other investigations would you like? You're going to think about doing?
Spinal CT would be a good idea because I'm thinking about possible acute bleeding.
Yeah.
With rocks and band, low hemoglobin. Well, it's pretty rare, spinal.
Yeah.
So it's bleeding that could cause also nerve compression.
Yeah. So spinal CT, to look for the bleeding, isn't it? Yeah, absolutely. Anything else anybody would like to do? Serum calcium? What was the serum calcium?
It was normal levels, yeah.
And adjusted calcium?
It was normal.
Okay. That's something to check, isn't it? Yeah.
No, we don't do them very much. We got a CRP, which is 8. I only tend to order an ESR when I'm looking for rheumatological, autoimmune condition, chronic inflammatory conditions. So I didn't have an ESR. Yeah.
Yeah. We do.
You can have quite normal CRP.
Yeah.
Very high ESR.
In some particular conditions like
myeloma.
Exactly, and polymyalgia. I'm going to keep going back to PMR, but
You're obsessed with polymyalgia. I can tell you now that isn't the diagnosis.
No,
he didn't have polymyalgia.
I know it's not polymyalgia, but I think you can have a normal CRP, can't you, in polymyalgia, but a very high ESR. Okay, so
just a question. In this patient, the pain was not controlled when he went to the radiology department.
Was the patient controlled when he went to radiology?
Pain-wise.
Why do you ask?
Well, because having experienced myself after a fracture and being moved 5 times from the radiology to the CT to whatever they needed to do to assess, it's so painful. And here, in the clinical exam, in the history, you're not very sure it's osteoarticular. You still have, and I found a suggestion of the hernia, a good one, actually, in this case. So, would you go immediately to a CT, or would you really stick to our cost-saving?
Yeah.
So the question is, would you go for a CT immediately? Because it would give you a bigger diagnostic yield and would look at several structures, whereas the X-ray was looking at just bone. I think there's an argument for it. I think we'd have got the same pushback as you. If I try to request a CT-PA to look for our problem PE, I get the pushback, do a chest X-ray first. That might reveal the diagnosis. It never does. And we do the CT-PA afterwards. But that tends to be a little bit of the guardianship of radiology that I notice in my clinical practice. So if I'd gone straight for a CT pelvis, I probably could have made a decent argument for it. But an X-ray we can get like that in 5 seconds in ED. And I thought maybe I thought there was going to be a fracture. And in fact, when I got the X-ray back and it said no bony fracture, I was not satisfied. And I think there was an occult fracture. For me, it's the not being able to, the weight bear. When someone's got really bad hip pain and they get a normal X-ray, and sometimes it's the physio, The physio the next day on the ward says, we tried to get the gentleman in bed 4 up. He could not even put an ounce of pressure through that hip. There's something wrong.
You see,
to me, I'm
it's
like,
a
we better do a
fracture.
CT
Yeah,
then,
exactly.
because that they've probably got a fracture. And sometimes it's a pubic ramus fracture, or something else in the pelvic girdle. But there's a crack in a bone is often my experience when the patient simply cannot wait there. So I went back and got a CT.
CT
I did.
pelvis or CT,
CT
abdo-pelvis?
CT pelvis for query occult fracture.
Okay.
Yeah. And it's interesting, but the report came back from there. We get a registrar report, first of all, and it said there is no bony injury, because that's the question I asked. Is there a bony injury? No bony injury. We went back and scratched our heads for a little bit. And then an hour later, the consultant radiology addendum appeared on the CT report. And it said, no bony injury. There is a retroperitoneal hematoma in the left hemipelvis, predominantly within the iliacus muscle. And it's big. So a big round of applause, because based on very scant information, someone in the audience made a diagnosis that I failed to get. So I tip my hat to you. Well done.
Why did you think
How
of
did you
that?
know?
Because you mentioned, very early on, you said, is this a hemorrhage within a muscle? Have you seen Ben's notes?
I thought about it because I had a patient that had something similar.
Yeah.
And it was a younger patient, and he didn't have any anticoagulation, but he had a trauma, like he landed on a parachute, and then his heart started to have like this very, very strong pain.
Okay.
And it didn't match the velocity of the trauma of the fracture, and he ended up having a hemorrhage.
So your past experience massively impacts on the diagnosis that we make in the future, doesn't it? And what I've started to notice now is when I'm working with medical students or very junior doctors, year 1 of their qualification, they don't see patients as much as they used to. Particularly medical students, they don't come on the ward as frequently as before. They say, I'm doing book work. And I'm like, you're never going to learn as much as when you're actually seeing patients, taking histories, examining them. And in your situation, you will never forget that case.
It always fascinates me whenever I say to someone, I'm impressed by it, I say, how did you know this? And the first thing they say is, well, I once had a patient
I've seen it before.
And it's like, it comes from your library. You have to have a big enough library. So when you meet new cases, you can contextually check it against previous experiences. And the only way to build that library is by just years of drudge work, seeing patients. And you can't get a library in your head in a library, in an actual library or in a lecture theatre. Well, you could, and we try to do that with the podcast. We're trying to help people listen and build up a little substitute library, but there's nothing for saying, I think I've seen this before. I think I've seen this before somewhere, and it turns out, and sometimes you're wrong, and you go chasing a diagnosis, and you go, oh, okay, maybe not, back to the drawing board. But when you get the diagnosis right, it comes from the experience, and I just find that really, really fascinating. And that's what you said. You've seen a patient like this before. I hadn't seen a patient with a retroperitoneal hemorrhage before. I remember learning about it when I was studying medical school, and I thought it was supposed to give you back pain. And I was quite cross, he didn't have back pain. And I thought it was supposed to, then I did, yes, of course, you can't stretch or distort the iliopsoas muscle. So that's why he didn't like me moving the leg. But I didn't realize the pain would sit in the hip. So that was really interesting. So that was the ultimate diagnosis, a retroperitoneal hemorrhage in the iliacus muscle, which forms the joins the psoas to form the iliopsoas.
So in a way, I'm going back to compartment syndrome.
It can cause compartment syndrome.
Cause compartment syndrome. And actually what's happened is the muscle is in a fixed, tight space, isn't it? So extra blood in it is sort of causing a compartment syndrome. Yeah. In the fact that it's stretching the compartment, it's causing pain. So that's why I thought about it with the tenderness and the amount of pain that he was in.
And when I did a bit of reading around it, it can also, when it's the iliopsoas muscle, it can cause compression of the femoral nerve, which can cause the altered sensation in the anterior thigh, which he did have. So there you go. So now I'll never forget that. You'll never forget that. Hopefully nobody listening will ever forget that. And that's the story for the library. Yeah. But listen, I've got a problem now. Okay. This man's on rivaroxaban because he's had previous DVTs and he has atrial fibrillation. But he's also got a bleed. And I've got to make a call. So first thing I want to do is actually assess the extent of the bleed. Is he actively bleeding?
Where's he bleeding from? You mentioned the femoral artery.
Oh gosh. No, I meant the femoral nerve.
Femoral nerve, sorry. You mentioned the femoral nerve. But where is the blood coming from?
Oh gosh.
Is he still bleeding? Do I need to get a surgeon involved?
So I did wonder about that, and I spoke to the surgeons, and they said it's not clinically a compartment syndrome. The CK is down. We would treat this conservatively. So that's me, doctor conservatively. So when surgeons don't want to get the scalpels out, patients come under medicine, and we sort of keep an eye on them.
Absolutely, but I'm still not happy.
Why?
Because I don't know enough about what's exactly going on in that muscle. So I guess it's watch and wait. And sometimes in medicine, it is about watching, isn't it? And going, but it does make me feel a little bit uncomfortable.
I didn't get the dimensions of the hematoma. I got the sense from the report that muscle was suffused with blood, but they didn't give me the dimensions. And I don't know if that would have helped my decision making. Like if they said there's a retroperitoneal hemorrhage and it's 3 by 3 centimeters, it's 8 by 8 centimeters. I don't know if that would have made me go, oh, stop rivaroxaban, continue rivaroxaban, because I don't know sizes. I don't know how big the muscle is to start off with, so I don't know how to make that decision.
Can I ask something? Was the CT scan done with angio contrast?
No, because I wasn't looking for a bleed. It was so he's asking if it was done with contrast. It wasn't. It was a plain CT scan of the hip.
Should we go back and do one with contrast? I think so too, and I think that would make me feel a little bit more comfortable about what exactly was going on.
So I think to pick up an arterial bloom on a CT angio, there has to be a pretty brisk bleed. I think 3 to 5 mils a minute has to be coming out for it to show up.
It's going to be getting
Okay.
I mean, it's just a thought because it's not something we see very often.
Yeah.
So when we come to managing it conservatively, I'd really have to think about exactly what I'm going to do.
Well, it's 5 to 6, right? He takes his rivaroxaban at 6 p.m.
Okay.
Do I give it or not? I've got a couple of options actually.
So
give the rivaroxaban.
Yeah.
Don't omit don't give it. Reverse it. Lots of people looking very worried at that option in the audience. Change it to maybe low molecular weight heparin. I've got a few options actually.
Okay, so we need to think about the reason he is on DOAC in the first place is because of atrial fibrillation and because of a DVT, you said?
Yeah, multiple previous DVTs.
Yeah. So he's probably on lifelong anticoagulation for that.
Correct.
So for the AF, he was in fast AF when he came in, it was 122,
Due
wasn't
to
he?
the pain, yeah.
Could we reduce, let's try and manage the AF as well and try and rate limit him potentially, which will reduce some of the risks associated with that.
How would you do that?
Rate limiting, I'd probably give him maybe beta blocker.
I thought about that. I just thought if the pain was controlled, I would watch and see. He didn't present to me as hypovolemic, is the important thing to say. And if he was fast AF and I thought he'd actually bled significantly internally and he was hypovolemic, I wouldn't give a beta blocker.
No,
I would give him volume.
Yeah, exactly.
He's presented euvolemic. But agitated, a sympathetic nervous system was very aroused. And I was minded just to sort the other bits out and hopefully the AF would melt, the rate would calm itself down.
And when the pain was under control, did the heart rate come down?
Did.
Okay, fine. So I'm happy with that. So I guess you'd do a CHA2DS2-VASc score to identify.
How would that help you?
It wouldn't. No, but I guess these are the sort of things that are going through my head.
I actually did do that. Yeah.
Did you?
Yeah.
So CHA2DS2-VASc, what's his orbit score? He's already bleeding anyway.
Yeah. His CHA2DS2-VASc came out at 4. So 4.8% risk per year of a thrombosis event. Does that inform anything really? Have you ever tried giving that to the patient?
They don't really. Yeah.
They don't like it. In my experience, the guidance also discuss risk of thrombosis with the patient and then come to a mutual collaborative decision about whether they should be anticoagulated or not. Just in my humble anecdotal experience, if you say to a patient, you have something called a CHA2DS2-VASc score of 4, this means you have a 4.8% of having a bleed in a year. It doesn't sit well with patients, and they often say, I don't know, doctor, what should I do? Yeah. Do you guys in the audience, do you discuss this with your patients, and do they find it useful?
Not in an acute situation like this.
Not in an acute situation.
Exactly. I
have to stop anticoagulation for 6 months or for a year. I think
absolutely. So in this patient then, who would stop anticoagulation?
Absolutely. So
we have probably 50% of the room who would stop anticoagulation. Who would continue a DOAC? We've got 0% who would continue a DOAC. Who would start enoxaparin?
Not now.
Not now. We've got probably got about a quarter of the room who would start enoxaparin. Who you said not now. Why not now?
Well, there comes again my experience.
Yeah.
Although I didn't study it, but low molecular weight heparins are even worse in terms of risk of
Bleed.
illness, even worse than DOACs. So, no, absolutely not. At this moment, we have to stop anticoagulation and maybe even revert it, because even though the hematoma is not very big, you have serious nerve compression symptoms. So you have an acute neuropathy, very serious. So you have to stop all revert anticoagulation, in my opinion.
So just to summarize that for the mic, we're talking about he's got an actual active bleed rather than a theoretical one with some evidence of nerve compression. We must stop all anticoagulation, including low molecular heparin, in the acute situation, and then maybe reevaluate after a period of time. How long?
Maybe if the pain doesn't stop or if the hematoma grows, maybe he has to have nebulization.
So considering
embolization,
If some 3, 4, or 5 days, it depends on the evolution, maybe you can restart.
So 3, 4, 5 days, if there was no signs of a worsening bleed. And did we ask, would anyone reverse the DOAC with a reversal agent?
Or if they're treating conservatively, then probably not. Surgical treatment, then it would make sense.
Yeah.
How do you reverse at your trust rivaroxaban? Do you know?
With a phone call to the haematologist.
Yeah.
and
what do they do?
And they will say, right, I've got this very expensive drug that's in the cupboard that costs £15,000.
It's 15k. I looked it up this morning.
£15,000
per one dose.
For one dose.
So me and you are not allowed to go within 100 yards
no.
of it. They do not trust us with that at all. So it is a phone call to haematology. In my hospital, not even haematology, the clotting doctor on call. And it's called andexanet alpha. I had to write it down. Andexanet alpha is a recombinant modified factor 10A protein. We used to give prothrombin complex, but now we have this drug. But I'm not allowed to sign off on it. So it would be reversing it with a super expensive but very effective medication.
But and you have to check the INR within 1 hour of giving it, don't you?
I do not know.
I gave it a few weeks ago for a huge bleed, varicose bleed, and it was prescribed and given. And the INR does change within 1 hour of giving it. However, if we were to reverse the medication, what's his increased risk of then developing a thrombosis within and causing a stroke?
I think the majority of the room have decided to stop anticoagulation.
For the moment.
For the moment. And that is what I did do. So we go back to heuristics. We talk about sometime podcasts. Heuristics are little maxims, shortcuts you take, often to justify a decision that you've made. One we use in the UK, if in doubt, do nothing.
Time.
So I said, I'm not going to operate. I'm not going to give him a DOAC. I'm not going to give him reverse. I'm not going to do anything. I'm going to stand over there and watch the patient, and I'm going to see what fate brings over the next 24 hours.
Thought of something. Obviously, he's in a lot of pain, but when the pain was under control, would we have that conversation with the patient about the blood thinner and say, this is the risk of a thrombosis, this is the risk of the bleed, I'm just putting it out there.
But
However,
the risk of the bleed is 100% because he's
still bleeding, exactly. But just let them know where our thought processes are coming from, and this is why we are stopping it. These are the reasons, and this is the rationale behind it.
And I did explain that actually because patients very rightfully can get a bit fretful about their medications in hospital because we make so many mistakes when patients come into hospital. Where's my yellow tablet? I always have that. What happened? I normally take this. I don't take this at 8. I take it at 9. And very particular. It's good because they keep us right a lot of the time. So I did say to him, you take a blood thinner. You're not going to have it because you're bleeding. I know you take it to stop you from getting blood clots, but at the moment, I really don't think you should have it. And he took that on board.
His platelets were low as well. So, he had a tiny bit low.
Yeah.
But, I would have stopped it too.
Okay.
Probably not as... I still have some concerns about stopping it because of the fast AF and the DVTs, but on balance of probabilities, the risks and the benefits, stopping it is the only way forward. And potentially restarting it in 5 days if the bleeding stopped, or it may even take longer.
I said actually stop it for a week and then reevaluate.
Yeah.
And I'll tell you what happened.
Yes.
So the patient improved with levels of pain. They were able to get out of bed and do a little bit of work with the physio. They were listed to be transferred for a period of inpatient rehabilitation at our local rehab unit to try and get some of the function back until day 7, when the patient suddenly became hypoxic, tachycardic, and developed respiratory distress. And we did a CTPA, and it showed multiple bilateral pulmonary emboli with evidence of right heart strain.
Oh, gosh.
Did I get it wrong?
No.
Would you do it differently if you had the same patient come in tomorrow? Would you do it any differently?
I can't help but it's a sliding doors moment. So I'm looking at my patient who's got multiple PEs because I stopped his DOAC. I'm also aware of this theoretical other patient who received the DOAC and then extended the hemorrhage to the point where they had compartment syndrome and had to have surgery. There's also a theoretical patient who received the DOAC, did not have an extension of the bleed and didn't get PEs and got discharged to his own home. I want that one, but I didn't get that one. My decisions and my clinical reasoning and judgment took me to the patient in front of me.
So how did you treat the multiple PEs?
It was a nightmare. We ended up treating it with split dose enoxaparin.
Okay.
Because at 7 days, we decided the bleed had probably stabilized, and we gave therapeutic dose enoxaparin, low milligram, but in split doses, so twice a day, thinking about the half-life. If he were to develop more of a bleed, it wouldn't be as long as the half-life of rivaroxaban. And that was how we did it eventually. The half-life of enoxaparin is about 5 to 7 hours, and rivaroxaban is much longer than that. It's up to 12 hours in older patients. So that's how I managed that.
Did you rescan the leg to see whether the bleed had got bigger? Had it, maybe that would have been I'm not sure whether we could scan it to see whether it was still actively bleeding.
Do you mean after he developed the PEs?
Yeah.
I didn't actually, because symptomatically he had improved. So I then switched my focus to the PEs. But I guess what I was trying to navigate in my mind, and with the young internist who I work with in the hospital, I wanted to not so much defend my position, but I wanted to explain what my mental landscape was. I didn't want them to think that I had made a monumental mistake and almost killed a patient, because I don't think that's a fair assessment of the situation. And I didn't want them to think that I didn't reflect. I want them to see me reflecting on things I'd done, because that's what I'd like them to do as well. We all want people that we train to become mature, reflective professionals who think about what they do and how they make decisions. So I try to exhibit that. So I said, well, let's just sit down and I'll tell you my thought process right now. I said, I don't think it was the wrong thing to do.
Yeah.
Je ne regrette rien, as Edith Piaf said.
Yeah.
I'm sure that's what she was singing about in that song, that patients with pulmonary embolisms. But I think that it was the right thing to do, because the greater evil at that moment was the bleeding, the retroperitoneal bleeding. And he didn't have PEs then. Or am I kidding myself?
I don't think there's a right or wrong answer in these situations, because either way, we've talked about all the different hypothetical situations and they're all really, really, really challenging. As soon as you admit somebody to hospital, the risk of a PE increases, the risk of hospital-acquired infection increases. So they've automatically, we stop the DOAC, so that increases the risk, and then we put them in hospital, we immobilize them, and the risk just goes through the roof. Yeah. So did he have thromboembolic stockings on? Did we try and prevent blood clots in another way? So that's something we could think about if we are, in this gentleman, if we are not going to be using DOAC. Let's go back to basics and let's put some, probably not on the bad leg, thigh-high venous thromboembolic stockings on, floatrons. Patients who've had orthopedic surgery have floatrons now, which pumps the vessels, then the lower limbs, and it prevents DVTs.
But who should get those, do you think, on a medical ward?
Patients like this.
Because my ward has 57 beds.
Yeah.
We have not got 50. We haven't got one set of floatrons.
But
57.
we do have stockings, thromboembolic stockings. So maybe it is just little simple things that are cheap. And this was a really difficult case. Not all cases are like this. So maybe floatrons we could have thought.
It was a tricky case. We've got a couple of questions in the audience, and we better wrap up soon. But before I finish off, I just wanted to say that this is internal medicine. It is juggling several systems and organs at one time and making the best decision you can with the resources and data you have in that moment by looking at the patient in front of you and then reacting to the outcomes of that, again, in a systematic way. And I think that It's based on the data I had, the resources I had, and the judgment I had in the moment when it was 5 to 6 and he was due rivaroxaban. I think it was a reasonable decision that I had made. I'm glad that people in the room thought it was a reasonable decision as well, and I hadn't gone completely mad. And it's always good to be validated that way. But also, I like to talk about cases like this because I don't want people to think, oh, you did the wrong thing. Because as you said, I don't think there is a wrong thing or a right thing. People might have made a slightly different direction of travel based on their own judgment, but the judgment is very individualistic and it's based on you as a doctor. And this is the responsibility that we have when we're standing at a patient's bedside, and it isn't easy. But it's also the part of the pleasure and the responsibility of being a doctor, which I quite enjoy in a paradoxical way, holding those decisions and that risk.
I guess this is where decision-making becomes a team sport. So if I had a case like this, I'd probably be going around to everybody saying, what would you do? What would you do? Just hypothetically, if you had a patient, what would you do? Maybe asking haematology for some advice, just for some, just to try and get, I don't know, an extra pair of hands or thought processes. Sometimes that muddies the waters. But
sometimes you get too many opinions.
But sometimes it can help clarify, potentially.
In my experience, haematology, they don't like to advise whether to anticoagulate. They'll tell you the dose once you've decided, but the decision is yours. It falls to us as internists to do. Yeah. And we stand at a position of having great oversight. We're not looking at one organ. We're looking at a whole. Exactly. And so sometimes, and I think it's a nice example of decision making, I thought, and making a judgment call in the moment.
Yeah, absolutely. So the question is, to anticoagulate or not to anticoagulate?
It's a risk.
It's a risk.
It's a risk, and you have to evaluate the risk and then make a call and stand by your call
with the information you have at that time. Exactly.
So before we finish, we have some questions from the audience.
Excellent.
Thank you.
I was just wondering for how long was the anticoagulation?
How long was he off anticoagulation before he had the decompensation? Was 7 days. It was on the 7th day, actually the day I was planning to restart it, or let's reevaluate the decision. Yeah. So you were going to ask a question.
Thank you. One thing that I thought about was the reason for the previous DVTs.
Yeah.
If he's a carrier of factor V ligand, for example, we would think he has a higher coagulable state. And then maybe an IBC filter would be something more easily good in this case, or a left atrium appendage, or something to prevent further events like this.
So the comment was about whether because he had previous venous thromboembolism events, had he ever been tested for any clotting disorder like factor V Leiden? And the answer was no. He had a second DVT, and that triggered lifelong anticoagulation, but he didn't have a formal diagnosis of a clotting disorder.
That is an excellent thought. Thank you. That's
But what did you then finally recommend when you discharged the patient? Because just body obviously needs anticoagulants long term, because this is the third venous thromboembolism. But you just hope that there will be no recurrent major bleeding.
So what was the discharge plan regarding his anticoagulation? He went home on split dose enoxaparin with a referral to a clotting clinic as an outpatient, and he was trained how to self-inject enoxaparin until then. He is someone who's had previous clotting events and a previous hemorrhage event on a DOAC. I would have been deeply uncomfortable about giving him a DOAC or warfarin long term after having a spontaneous retroperitoneal hemorrhage, which, by the way, has an eponymous name. Do you know it's called a Wunderlich syndrome? Wunderlich. Sorry if there's any Germans in the audience, that's how. But so I was never going to give him a DOAC again, and I didn't want to give him nothing, because I tried that and it got me into a pickle. So he went home on a real compromise, which was a split dose of aspirin, which actually went through an MDT process. That wasn't just from me, that was me in discussion with a few other people from the hematology, and then he went to a hematologist in clinic. And did I hope? Yeah, I did. We went home and I just hoped everything would be okay and be held in balance.
Question at the back.
How did you control his pain?
How did you control his pain? Yes, Ben.
The pain required quite a lot of aliquots of morphine when he was in the ED. When he got to the ward, it settled down quite a bit. And I wonder if that was because the bleeding had stopped and the muscle was not developing in size. And then he was on Oromorph for a while. Pretty decent doses, like 20 milligrams 4 times a day. And then I think it got downgraded to some weak opiates and a paracetamol on discharge.
Do you think reducing the uncertainty is what's happening?
Yeah.
Absolutely,
Yeah.
yes. I think being
Yeah.
on a trolley in A&E must amplify any kind of pain and distress by a factor of about 50. So when people are more settled down, pain absolutely settles down. That's certainly my experience.
Absolutely.
I have two small questions. Now you decided like 7 days now into coagulation, but if you wouldn't go up to the patient and say, let's restart it now, would he want it to have started earlier because he had this much pain and probably would avoid it? I think if he would have made a decision, probably he said, no, let's wait a moment until we're sure.
So I'll just respond to that first. So if I went to the patient on day 7 and said, good news, sir, we decided to restart your anticoagulation, what would he have said? Honest answer, I don't know, because I never got to that point. And he may well have said, as you suggest, I don't know, thank you. I've been to hell and back in the last 7 days. I'll take my chances. We now know he wouldn't have got very far, but he would have had a blood clot pretty soon. But he may well have declined it. And I'm offering the medication rather than, forcing people to take it. Would be my first answer.
And then the second question is, so did you retest his hemoglobin over the consecutive days?
Did I recheck his hemoglobin? Yes, he got daily bloods and it stabilized. It didn't sort of drift away from that value of 99, which indicated to me that maybe there was no active bleeding. Yeah. There are lots of other things to take into account when you're tracking bleeding with the hemoglobin, which is the patient's fluid status, hydration, and things like that. But it didn't keep dropping.
Final question?
It's an answer to the question.
Okay, excellent.
Please.
You said, how long should you have to put less one off the DOAC? Just, I think the most recent guidelines would say high-risk patients for 4 days is the, if the patient is going for surgery at the high risk like this man, 2 days before and 2 days after is what they do.
So there's data suggesting withholding a DOAC for 4 days in the event of a bleed.
Patient
yes.
who's going for surgery or who's had
yeah.
bleed like this, they'll say for surgery it's 2 days before, 2 days post. But in someone who's had a bleed, it's about 4 days in total.
Well, now we know. So 4 days is the answer. Should we have that as the take-home message then of the podcast? And so that's something we've learned.
Yeah. So take-home messages then. Number one, it's been brilliant to record a live episode of the podcast. It's slightly crazy, but I've loved it. And I think the key takeaway message, and we often talk about this in a lot of our episodes, is there is no right or wrong answer in medicine. Yes, it is a science, but also there's a little bit of art in medicine. We're in Florence, one of the most beautiful cities, so there's huge amounts of art, and often medicine is an art rather than a science sometimes.
A bit of both.
A bit of both, exactly. And thank you for bringing that challenging case to us. Thank you, everybody, for listening. Thank you, everybody, for joining in. And if you have a listen, please rate, review, and share this podcast with everybody who you think would like to listen. Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.